Hello, I'm Virginia Haggart. I'm the Senior Lecturer in Nursing at Deakin University. And on behalf of Distinguished Professor Anna Peters, who's the Director of the Deakin Institute of Health Transformation, I welcome you to the Professor Tricia Dunning Annual Lecture. Before we start, I'd like to acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land that we're meeting today, and to acknowledge elders past, present and emerging, and any First Nations people who are here today. Yesterday was World Diabetes Day, and the theme was putting wellbeing at the heart of diabetes care. And diabetes and wellbeing is the topic of the lecture today. This is the first lecture in a new annual series in partnership between Diabetes Victoria and Deakin to celebrate World Diabetes Day and to honour Professor Tricia Dunning. Tricia was universally loved and respected as a diabetes educator and an academic in the School of Nursing and Midwifery, and was chair in nursing at Barwon Health and a board director of Diabetes Victoria, among her many accomplishments and appointments. Her main focus, though, was on person-centred care and putting wellbeing at the heart of her diabetes care and in her research and how she advocated for others. Each year, Trish gave an annual lecture on World Diabetes Day at Barwon Health, and up until 2019. So we're pleased to name this inaugural event after Tricia with the blessing of her family. I'd like to thank Diabetes Victoria's CEO, Glenn Noonan, for hosting the event at Diabetes Victoria today. Our speaker today is Professor Jane Speight, who's the Foundation Director of the Australian Centre for Behavioural Research in Diabetes, which is a partnership between Diabetes Victoria and Deakin University. Jane is a chartered psychologist and fellow of the British Psychological Society and fellow of the Royal Society of Medicine. She's Australia's leading behavioural diabetes researcher and ranks in Stanford University's world top 2% of scientists. She leads a portfolio of research in the behavioural, psychological and social aspects of diabetes and leads the world in her research, particularly around the area of diabetes stigma and language around diabetes. Since opening the ACBRD in 2010, Jane has ensured that wellbeing is at the heart of diabetes care. And the emotional aspects of living with diabetes are recognised and acknowledged, and people are supported to achieve optimal psychological and physical wellbeing. So I'm sure you'll be inspired by today's lecture. Thank you, Jane.
Thank you so much, Virginia, for those very warm words of welcome, and thank you to the Institute of Health Transformation and Diabetes Victoria for inviting me to give today's lecture. As Virginia mentioned, putting wellbeing at the heart of diabetes care is the theme for the International Diabetes Federation's World Diabetes Day campaign, and so it's also the title of my lecture today. But I thought that I might be a little bit cheeky and put together a subtitle for my lecture today, which is Diabetes Care as if People Mattered. And this is a little bit of a controversial way of putting it, I think, but deliberately so, to make us really consider what we're expecting people with diabetes to go through, to endure as we communicate with them in clinics, in consultations, in campaigns, in our everyday lives as we interact with people living with and affected with diabetes. Because caring for people with diabetes is really important, not just caring for their diabetes. So what I'm proposing to you today is a diabetes wellbeing manifesto, if you will. This comprises 7 key elements to improve communication, protect the self-esteem of people affected by diabetes, respond to individuals' differing needs, help people with diabetes to learn about their own individual responses, help motivate self-care, monitor psychological well-being, and organisational changes to optimise psychosocial aspects of diabetes care. All of these are really important for the well-being of people with diabetes, and we need to consider what well-being really means overall. Before we go much further, I do have some disclosures to reveal. Industry funding, copyright holder of several questionnaires that I may or may not mention today, some programs that we deliver at Diabetes Victoria and the ACBRD, and of course that my role is funded by Diabetes Victoria, so I will be giving a few shout outs, but I do acknowledge my bias. I'd also like to acknowledge the traditional custodians of the lands on which we're meeting today, the Wurundjeri people of the Kulin Nations, and pay respects to elders past, present and emerging, and recognise that Indigenous people living with diabetes really do experience some of the most devastating impacts of diabetes amongst our community. I'd also like to acknowledge all people with lived experience here today and joining us on Zoom or watching this recording, because people living with diabetes are the why and the how of our shared research endeavours, and I respect and value their generous contributions, which inform and improve our research and other people's research to support advancements for all people affected by diabetes. And it's a real privilege to work with and for them. As Virginia mentioned, today's lecture and indeed annual lectures hereafter will be named after Emeritus Professor Tricia Dunning, AM. Tricia was a wonderful woman, a wonderful health professional, researcher and colleague, and someone I'm very proud to say was a friend as well. When I first came to Australia in 2010, Tricia was one of the first academics at Deakin that I met. She gave me an extremely warm welcome, and indeed we collaborated with each other ever after that. Tricia's pictured here with her wonderful husband, John Dunning, who unfortunately died shortly after Tricia, just within a year or so. On the screen here are some of Tricia's publications, 3 of her books. She actually wrote many more books. I wanted to highlight to you the words of these books, because the one on the left there is titled Care of People with Diabetes. That was published in 2008, long before we had position statements on the language used in diabetes, when many textbooks would be referring to clinical management of diabetes or problems with diabetes, clinical problems and so on. So Tricia was really an advocate for language long before anyone else was really talking about it in academia. She also recognised that diabetes education and the care of people with diabetes is as much an art as a science, and I really valued her consideration of that. And she also recognised the care and the dignity required, particularly for older people living with diabetes, and in some of her later work towards the end of her own life, recognising the need for really very carefully considered end-of-life care for people living with diabetes as well. So what I also wanted to say on that slide, sorry, it's just moved on before I was ready, is that one of my first publications here in Australia was the Diabetes Australia position statement on language, which Tricia was a co-author on, and I was really delighted that she was able to work with us on that. And indeed, she worked with us as well on the revision 10 years later. And there are a few other publications on language that we worked on together that are probably less well known than that one. So Tricia has really been an inspiration as much as a colleague over the years. So we're here to talk about well-being, because it was Wellbeing Day, it was World Diabetes Day yesterday, with the theme of well-being. And the International Diabetes Federation encouraged us all to let's talk about well-being for a better diabetes life. So what I want to talk about today is what we mean by well-being, why it's important, and really just encourage us all during this hour to think about, would people with diabetes flourish if we focused more on their well-being than on the clinical outcomes? What would diabetes care look like if we promoted people's well-being and that was our main aim? And think about the progress that we've made in this area, the challenges that remain, and the opportunities that we still have to make a difference here. So the IDF had a survey that they released yesterday, and the findings are really very consistent with the findings of our own research over the years that demonstrate that diabetes is impacting on the mental well-being of around 3 in 4 people living with diabetes across their lifetime. The common factors that are impacting on people's well-being, around 4 in 5 people are fearing the development of complications. Around 3/4 of people are concerned about the daily management of diabetes, and just over half are concerned about stigma and discrimination. In our own estimates, and indeed an international consensus shows stigma to be a lot higher on that list. Sorry, again, my slides moved forward. The importance of all of that is not only just for people's well-being, but also that almost 80% of people are reporting experiencing diabetes burnout, and 3 in 4 of those affected by diabetes burnout are reporting stopping or interrupting their diabetes treatments due to stress or feeling overwhelmed by their diabetes. So this is a very serious issue indeed. And the other thing that the IDF has pointed out is a clear call for better support, with 3 in 4 people living with diabetes seeking increased support for their emotional and mental well-being. And it's not surprising that we see those statistics when we think about what it takes to live with diabetes. It's so much hard work. People say it's assumed that if you try, you'll have a perfect HbA1c. That's incorrect. I devote so much attention to it, and I'm still battling it every day. And people say also how difficult the demands of the constant focus are and the impact of good diabetes management on quality of life. So diabetes takes a lot to manage. It takes attention to healthy eating, physical activity, medications, monitoring, health checks and screenings. And every day there's decision making to do, there's problem solving to do, and there's coping every day. So the IDF has also put out a couple of statements from the president of the IDF, who said, according to latest statements, over 500 million people are currently living with diabetes, with 1 in 8 people set to be affected by 2045. Bearing those figures in mind, our survey suggests that the mental well-being of over 400 million people could be impacted due to the daily burden of managing their condition. And while diabetes affects both physical and mental well-being, care often focuses only on blood glucose management, leaving many overwhelmed, and we need to look beyond blood glucose for a better diabetes life. That was a really important acknowledgement from Professor Peter Schwartz. And another statement from a health professional in South America corroborating this says, mental well-being is not something that most doctors are concerned about because in the consultations, they're focused on treatment, on reading the labs, on prescribing. When someone with diabetes comes to the consultations, if we see that person as a person and not as a patient, we're seeing a human being. So we'll treat them differently. If we do that with every patient, the world can change. These are really powerful statements and really important acknowledgements of the limitations of the way in which we currently serve people with diabetes in clinical consultations. And while the treatments and the technologies are improving all the time, and we must acknowledge that they are having huge benefits for people living with diabetes for both their physical and their mental well-being, we also know that there are still barriers to accessing those treatments. There are still barriers to using those treatments and technologies, and there are still many burdens as well, not least the burdens of wearing devices every day, engaging with them, engaging with other people around what it means to be wearing those devices every day. And there's a lot of work to it all with no break. One of the studies that we've had the pleasure of working on recently is with the Open project in Europe. And Jasmine Shipp, who was a PhD student with us at the time, did this survey of people using what's referred to as open source automated insulin delivery. So this is a type of technology where people are downloading algorithms from the internet that they can adapt themselves for how they want to use their devices and really manage their diabetes their way with confidence. And so this survey involved 451 people who were using devices in this way and 141 people who were using other technologies. Important to note that a third of those people were using commercial automated insulin delivery systems as well, so the best technology that we have available commercially. And on the right-hand side of this slide, you can see the outcomes that we looked at in terms of generic diabetes-specific and hypoglycemia-specific constructs. And we looked at diabetes distress, fear of hypoglycemia, and showed that both of those were reduced amongst the people using automated, so open source automated insulin delivery, that general emotional well-being and diabetes-specific positive emotional well-being were also improved for those people using open source, treatment satisfaction was improved, sleep quality was improved, and overall diabetes-specific quality of life was improved amongst those people using open source. Now, some people would say, well, those people have got access to all that technology. They're clearly highly motivated. They're very well placed to be just doing better generally than the other people. But I would like to point out to you that all of those effect sizes are medium to large effects, which is quite unusual for these types of studies. And those differences were not due to gender, ethnicity, education, income level, type 1 diabetes duration, or their most recent HbA1c. So there's some really powerful findings there from a survey of people who are doing diabetes their way with confidence. So what is well-being? Well, well-being is our internal positive view that we are coping well psychologically with the everyday stresses of life, and that we can be productive and fruitful, that we feel happy and live our lives the way we choose to. And for people living with diabetes, that's no mean feat when we consider, as I've mentioned, all of the treatments and technologies, all of the decision making and so on that needs to go on in the background. It's really easy to understand how well-being can be depleted as a result of living with this condition. Now, there are many guidelines nowadays that focus on psychological care and provide recommendations for monitoring the well-being of people living with diabetes. Amongst these, almost all take a focus on mental ill health or mental health problems, if you like. So they look at monitoring depression, depressive symptoms, diabetes-related distress. They don't necessarily take a look at the positive aspects of well-being and the extent to which people are feeling well with their diabetes. They just look for the absence of negative impacts. And yet there was one guideline 30 years ago this month, was published by the working group of the World Health Organization's Regional Office for Europe and International Diabetes Federation, the St. Vincent's Declaration Action Programme for Diabetes. This was the first ever guideline for encouraging psychological well-being. And we have a lot that we can learn today from this guideline that's 30 years old. So I mentioned a manifesto, and it was a bit cheeky of me because I'm sure at that point you thought, oh, Jane's come up with a few interesting things here. As it turns out, Jane's not so smart, but the people who wrote that guideline were incredibly smart 30 years ago. So these were their 7 points for improving the well-being of people living with diabetes. These were the points that they recommended. They had long lists under each of these of the types of things that could be done to improve communication, to protect self-esteem and so on. And I'm going to talk a little bit about where we've got to with all of those. Now, again, Jane's not so smart because Jane's very smart. Jane works with some very smart people. So what I'm going to talk to you about today is not just my own opinion of reflecting on those guidelines, but 5 years ago, I was fortunate to work with Crystal Hendricks, who I'm delighted to see here again today, Franz Power, Tim Skinner, and Frank Snook, all of whom are really very knowledgeable and thoughtful about the psychological well-being of people with diabetes. And so we took it upon ourselves to reflect on these guidelines at the point of 25 years since they'd been published, and to consider the extent to which they were still relevant and the extent to which we'd made progress in these areas. So that's what I'm talking with you about today. So we deemed that for 3 of those areas, responding to individual differing needs, helping people with diabetes to learn about their own individual responses, and helping to motivate self-care. All of these are actually probably considered now to be expected standards of contemporary diabetes care under the framing of person-centered care. And as Virginia mentioned earlier, Tricia Dunning was a great proponent of person-centered care. And so this terminology has made it into many guidelines over the years, and the most recent of these being the 2 that I'm showing on the screen here, on the management of type 1 diabetes from the American Diabetes Association and the European Association for the Study of Diabetes, and also for the management of type 2 diabetes. Sorry about my slides moving on. And on the right-hand side, you can see a very complex diagram that I'm not going to go into that talks about how you put person-centered care into action. But the problem here is that it's really not always happening as well in practice as we see written in the guidelines. And this person with diabetes told us, "I know myself better than anyone. Doctors read out of a book and expect that what they read is how it works." Well, it's not. Everyone is different. And perhaps the problem around person-centered care is that it doesn't feature very heavily in the textbooks that our endocrinology trainees are reading when they're training to become endocrinologists. There are 232 chapters in these 3 very popular textbooks of diabetes. And I will give a prize to anyone who can tell me, oh, too late, just 3 chapters on the psychosocial aspects across those 3 books, which is quite extraordinary when you think about how thick those books are and how much information. So it tells you a lot about the complexity of diabetes, that we do need 232 chapters on what diabetes is and how it's managed and so on. But it's quite extraordinary to me that there's only 1 chapter in each of those books about the psychosocial issues. So at the centre, we've done some work around understanding what people with diabetes experience in their clinical consultations and what they want from their health professionals during those consultations. And this paper was published, led by Eloise Litterbach in our team, a few years ago now, from our Diabetes Miles 2 study. And in this study, it was a national survey, so we had a lot of people responding to this. We had just over 1,300 people respond to this question of what I wish my health professionals understood. 1 in 3 of those respondents reported positive experiences about their health professionals. They were happy with the care they received. Or one person told us, "I've hunted around for years to find a decent endo and finally have one." So they were now happy, but they hadn't been happy for quite a long while. But the other 2/3, and sometimes some of the people who were happy, still had some things that they would like to tell us about what their health professionals should understand. And those 7 themes that we pulled from those qualitative responses were the barriers to diabetes management, that it's easier said than done. They want the health professionals to understand the full impact of living with diabetes, that they want and they need and they deserve more from their health professionals, that the health professionals' judgments, assumptions, and negativity are not helpful. They want the health professionals to understand more about diabetes. And also, they want the health professionals to understand that they are indeed experts in their own diabetes. Now, just one of these themes here, the judgments, assumptions, and negativity, I'll just pull out for you, just so you can see a couple of quotes that came from that. One person in particular said, "I'm not going to waste my time seeing any health professional who bullies, treats me like a bunch of numbers, and thinks that fear is helpful." People turn away from these kinds of consultations. They turn away from these kinds of health professionals. And so we have problems in diabetes care with people not attending clinic appointments, disengaging from healthcare, disengaging from the healthcare that they really need to help them to live long, healthy, happy lives. And I would advocate in large part that this is as much due to health professionals as anything else in terms of the experience that people are having in those consultations. One person said, "I had a lapse in my care because my diabetes educator was very hard, so I gave up caring." Here's another study. It doesn't come from our group. This is from Starkman and colleagues. They did an observational study of clinical consultations with teenagers with type 1 diabetes, their parents, and their clinicians. They found that in those consultations, when the consultation was framed around the teenager having what I would refer to as a high HbA1c, what the authors referred to as uncontrolled diabetes, they found that the emotional reactions of all 3 parties in that consultation were similar. So everyone in that consultation was feeling guilty, feeling like a failure, feeling judged and frustrated. Everyone was feeling that their efforts are devalued, and everyone was feeling that their efforts are futile, and no one knew what to do. The only person in that consultation that was feeling dehumanized was the teenager themselves with type 1 diabetes. Now, while the emotional reactions were similar amongst those three parties, the behavioural responses differed. So the clinicians became more focused on the diabetes as opposed to being person focused, distancing themselves from the young person and their parents. The parents became angry, they nagged, threatened, and often blamed and shamed their teenager with type 1 diabetes. And the teenager tended to rebel and was less likely to undertake the tasks that they needed to do to manage their type 1 diabetes. So there's some really concerning patterns here in terms of how that consultation is handled. We can really appreciate how everyone there is trying to do their best, but it's just not working out as well as it needs to. We need to improve clinical care, and we need to do so because higher continuity of care is associated with lower mortality overall. This review paper from BMJ Open shows that continuity of care with doctors matters. In fact, it's a matter of life and death. They found that amongst people who had lower continuity of care, they were more likely to die early. Now, they don't really have good data about why that is, but they posit that they have a hypothesis. So the perception of the clinician as trustworthy and more responsive. So if the person in the consultation feels that their clinician is trustworthy, if they feel that they can trust them with information about how they're feeling, about what it's like for them to manage their condition, then they're more likely to tell them those things, be open with them about it, and then they will get the treatment and the management that they need and the recommendations that they need from that health professional who are going to be able to be more responsive to their needs. So there's greater disclosure between both parties, better tailoring of care to the person's needs, and greater uptake of preventative strategies and other medication taking and so on. So it's a really important clinician-patient relationship. But as you all know, probably most of you know, the work that we've done and others have done in this area shows that the typical diabetes language is sadly lacking. It's quite negative, it's distressing, upsetting, it makes people feel guilty and anxious, frustrated and judged. It contributes to social stigma and discrimination. It's really unrealistic and inaccurate in terms of what it takes to live with diabetes every day. It affects people's willingness to take their insulin, it affects their glucose levels, it affects their motivation for self-care. It alienates and isolates people with diabetes. It contributes to burnout amongst not only people with diabetes, but also amongst clinicians. It affects clinician trainees' interest in specialising in diabetes, and it affects clinicians' attitudes to treatment and advice. At diagnosis, the language used is often quite negative and has a lasting impact on the person living with diabetes. So there's a lot that we need to do, and this is why the language position statements all around the world are so important. So as I mentioned, we published a position statement in 2011. We revised that in 2021 as Our Language Matters, improving communication with and about people with diabetes. There's also, this is an academic paper, but there's also a version of this that's been published on Diabetes Australia's website that's far more accessible for people. Both of those versions include latest evidence around the language used, 2 new acronyms, CARE, not BIAS, that I'll come on to later, and examples of how to change our written language. So we really updated the position statements to provide even more practical advice for how people can improve their communications. So improving consultations goes much further than just the language that's used. We also need to be person-centered, not just considering what the health professional thinks is necessary for the person in terms of their management and their treatments and technologies, but actually addressing the problems that the person may be having with managing their diabetes, and in particular, how it might be impacting on their well-being, and then how that might be having a flow-on effect to other areas. So this study has been led by Edith Holloway in our team. This has been a randomized controlled trial of an intervention that we've called LISTEN, which is low intensity support by a telehealth enabled network that was supported by Diabetes Australia and the TTRA. We had 429 adults with type 1 or type 2 diabetes randomized to either the LISTEN intervention, which was up to 4 weekly telehealth sessions of brief problem-solving therapy supported by a diabetes health professional, or usual care, which was their usual diabetes management plus access to some freely available web-based resources about diabetes and emotional health. And what we found in this trial is that the LISTEN group had a significantly greater reduction in diabetes distress over the 26 weeks of the trial compared to those receiving usual care. And the LISTEN group also showed greater improvements in general emotional well-being and coping self-efficacy, or their confidence around coping with their diabetes. So the conclusions from this trial are that upskilling diabetes health professionals to deliver problem-solving therapy as part of the LISTEN program has the potential to address unmet needs of adults with elevated diabetes distress. And what I'm not showing you on this slide is that there's also some flow-on effects for diabetes management, and it's also a cost-effective way of delivering care. So moving on then, so we've talked about person-centered care. Two other aspects of the guideline from 1994, the recommendations were to monitor psychological well-being and organizational changes to optimize psychosocial aspects of care. I've already mentioned that most of the guidelines published since then have focused on psychological or mental health problems rather than positive mental well-being. And also shown on the slide here is the Australian National Diabetes Strategy, which has recommendations to provide mental health care, which involves monitoring for mental health issues, assessing mental health at diagnosis and annually, and promoting mental health services. Now, as I've already shown you with the IDF survey, diabetes distress is common. These are our own findings from Diabetes Miles and other studies that we've conducted, which really shows you the breakdown of what diabetes distress looks like across types of diabetes, types of treatments, and also for different age groups. So you can see here that diabetes distress is least common amongst adults with type 2 diabetes who are not using insulin, and it's most common amongst young adults with type 2 diabetes, closely followed by teenagers with type 1 diabetes. And diabetes distress is consistently associated with lower levels of self-care and higher HbA1c. So we need to improve clinical care. We've established that. We know that around up to 30% on average of clinic appointments are not attended. This systematic review that was published in Diabetic Medicine shows that actually the range of non-attendance can be anything from 8% to 76%. But what they also did in this review was to look at why people are not attending their diabetes clinic appointments. And of course, appointment logistics come into play here, the timing of them, the costs of them, access barriers, and so on. But also, there are two other key issues here. The beliefs of people with diabetes about their diabetes and about the treatment of diabetes, the distress they're feeling, their ability to cope with it. And when they're feeling distressed and they're not feeling able to cope, they don't come to see their health professionals because they don't want to be judged for what they might not be doing as well as their health professionals think they should be doing. And so that brings us on to point C there, which is the clinician relationship. So the relationship between the person living with diabetes and the clinician. So we can call these the ABCs of why people don't attend their clinic appointments. Now, to try and deal with the diabetes distress and also the clinician relationship issue, we worked for several years on a practical guide. It was initially called a handbook, now a practical guide on diabetes and emotional health, led by Crystal Hendricks and Jennifer Halliday and our team, also with the support of Linda Beanie over in New South Wales, another excellent clinical psychologist working in diabetes. And this practical guide has several chapters in it. This one is focused on diabetes distress that I'm showing you on the screen now, quite slowly by the looks of it. So you can see here that it shows you what is diabetes distress, how prevalent it is, a model of care, so the 7A's model of how to be aware of diabetes distress, how to ask questions about it, how to assess it, how to arrange care and so on. Case study about a person living with diabetes distress and how that consultation goes. Questionnaires that can be used for the assessment of diabetes distress, and then other resources that the health professional or the person with diabetes may want to access after the consultation. And this practical guide has been adapted and adopted by Diabetes UK, for health professionals in the UK, by the American Diabetes Association, for health professionals in the USA. Most recently has been the whole thing has been translated into Spanish by the Spanish Diabetes Society, and also the diabetes distress chapter of the practical guide has been translated into Danish. So this is really a very authoritative practical guide that is being well recognised not only here in Australia, but in other countries across the world, for being a really useful resource that is very much needed. And as good as it is, we've also looked into the extent to which it's being used in practice. And so bringing you back to the Australian National Diabetes Strategy and its recommendations, we see in a survey that we did with just under 200 health professionals here in Australia that in line with the strategy, around 72% of health professionals say that they're asking about emotions in their clinical consultations, and around 59% are referring to mental health professionals. But in the middle here in this bar chart, you can see that far fewer are formally assessing mental health at diagnosis, formally assessing mental health at their annual reviews, and formally assessing mental health as and when needed. So it begs the question of whether or not they're actually capturing all of the support that may be needed for the person living with diabetes, because they're not doing these formal assessments as the national strategy recommends. And when we asked those health professionals what are the factors that are associated with them putting those recommendations into practice, we found that the enablers were team communication in 50% of cases, work culture in 48% of cases, and also knowing that people with diabetes are willing to talk to their health professionals, which other work that I won't show you today also shows that they definitely are willing to talk and wanting to talk with their diabetes health professionals about their emotional health. What the health professionals are hindered by is healthcare funding. So 75% are saying that the funding available for clinical consultations and so on is hindering their ability to do good work in this area. 71% are saying that there's a lack of availability of mental health professionals and a lack of knowledge amongst mental health professionals about diabetes. And 61% are hindered by their perceptions of the time that it takes to do this in their clinical practice, which I suspect also comes down to the work culture and team communication as well. Linked to that, a few years ago now, the Lancet Commission on Diabetes provided a paper called Using Data to Transform Diabetes Care and Patient Lives. We looked at that paper and identified that there was a big omission in terms of the data that the Lancet Commission was proposing needed to be collected on a regular basis. And that was data on diabetes-specific distress. So everything that I've been talking to you about so far and what the World Diabetes Day theme is advocating is that we need more support for people experiencing diabetes distress. But if we're not measuring that and we're not routinely collecting data on that in practice, then how do we know whether people are experiencing diabetes distress? And importantly, how do we offer them support? And then how do we know that that support has actually been effective for them? So we really do need to make sure that diabetes distress is captured in the clinical records and valued as much as all of the other clinical endpoints that are recommended in this Lancet Commission. And that's why we wrote a commentary letter in response to it. And finally, the final 2 points that I wanted to come to in the 1994 guideline recommendations are actually the first 2 recommendations in that guideline, which were about improving communication and protecting the self-esteem of people affected by diabetes. So this quote on the right-hand side is from a person with type 1 diabetes, and it says, "Diabetes consultations often feel like a one-way street. It's the professional telling you what you need to do, and there's not a lot of exploration of how difficult that may be for you or how worried you may be about it. They don't necessarily explore with you how you're managing within yourself. Being able to talk about these things makes you feel that the health professional is actually interested in you as a person and in your situation. It's very empowering and validating. It makes you feel that it's okay for you to have these concerns and anxieties and fears and feelings, that it's actually normal and okay." So improving our communication in consultations is not just good in terms of the consultation and making sure that decisions are shared and communicated well, but it's also about protecting the self-esteem of people with diabetes and making sure that they feel that their experiences are valid and acknowledged and valued. That quote's actually in our practical guide. Now, this cartoon is actually one that Tricia used in several presentations over the years that always amused me, particularly given her love of shoes. So the single biggest problem in communication, as George Bernard Shaw said, is the illusion that it's taken place. And for anyone back that can't read it, the cartoon says, "To stay young, the doctor said to exercise and eat the right foods. What? I thought he said accessorize and buy nice shoes." And Tim Skinner in our group has done some of the only work in this area that really looks at the extent to which communication is effective in clinical consultations for diabetes. So this slide shows you the discrepancies between the person with diabetes and the health professional's recall and perceptions of an outpatient consultation. The circles on the left show you the congruence in recall of topics discussed. So the health professional and the person with diabetes agreed on 100 topics that were discussed in consultations, but the people with diabetes recalled another 80 topics that the health professionals didn't recall, and the health professionals recalled another 142 topics that the person with diabetes didn't. Perhaps even more concerningly is the congruence in the recall of the decisions made. And so you can see here that there's insufficient overlap between these 2 circles, shall we say. And that people with diabetes and health professionals disagree on the goals set 44% of the time. And Tim and his colleague Tracy Parkin concluded that the results of this study highlight a significant problem in patient-professional interactions, which is that the 2 parties concerned seem to recall different consultations. Now, Tim followed this up with another study a couple of years later about the accuracy of recall treatment decisions. So it's one thing to say that they disagreed on the topics and the decisions that were made, but actually how accurate were either of them in their recall of those. So in this pie chart, which is a little bit obscure with all the shading and the lines going on here, but over on the right-hand side here, this third, if we go from the top right, neither the person with diabetes nor the professional correctly recalls the treatment decision. So in a third of the consultations, neither the person with diabetes nor the health professional is correctly recalling a treatment decision. On the left-hand side here, 40% of consultations, both the person with diabetes and the professional are correctly recalling at least one treatment decision. Not all of them, just at least one. And then in the middle here, we've got 20% of consultations in which the professional recalls at least one correct decision, but the person with diabetes recalls none of them. And then 7% of consultations where the person with diabetes recalls at least one correct treatment decision and the professional recalls none of them. So a lot of discrepancy here in terms of accuracy of recall of what's going on in consultations. And Tim and his colleagues concluded in this study that the implications of these results are substantial. If these incorrectly recalled decisions are recorded in the clinical notes, this may lead to people with diabetes being inappropriately berated at follow-up appointments for not complying with these decisions, either by the same or by a different health professional. These results also may help explain why so many health professionals become frustrated with people with diabetes not doing what they've been told to do. So it's really clear from these couple of studies, and they are two of the only studies available to us, and we really do need more research in this area and more recent research. These were published in the mid-2000s for understanding what's going on with communication. So I come back then to our practical guide. The first chapter of this practical guide is about communication and engagement. This work is not just our thoughts about this. This is based in evidence. It's based on clinical insights, very experienced clinicians working on this. And Jennifer Halliday led the formative development of this practical guide, supervised by Crystal. And it's part of Jennifer's PhD work, whereby she also included co-design with people with diabetes and with health professionals to make sure that this was a guide that would truly be what people with diabetes want from their clinical consultations and what health professionals would also find practical to provide. So I encourage anyone who hasn't already taken a look at that particular chapter. I think people often think about the diabetes distress chapter and the other chapters around the mental health problems that are addressed in this practical guide, but actually going back to literally square one on communication is a really good idea and very important. So of course our language matters. So I'm sure that anyone joining us today would know that this is an area very close to my heart, and I've mentioned already very close to Trisha's heart as well. And I've already mentioned the Diabetes Australia language position statement. It's now been followed up by position statements in 19 countries around the world, at least, certainly, and counting. They're coming online literally every few months. So it's really quite remarkable to see this as a growing movement around the world. There's a huge amount more work that needs to be done. Just because these position statements exist doesn't necessarily mean that people are using them all the time and using them as well as they could do. But it's fantastic that we have these, because a decade ago we didn't, and I think the world was a poorer place as a result. So I think we are making progress in this area. As I mentioned, we updated the Australian position statement a couple of years ago, and we included these acronyms to remove the bias from the language that we use in diabetes. Bias stands for blame, irreverence, authority, and stigma. And that we need to use language that shows that we care about people with diabetes. So it needs to show that we're curious. It needs to show that we're being accurate in our understanding of diabetes, respectful and empathic. And we hope that those two acronyms help people with remembering how to mind their P's and Q's. But it's not just about the words that we use in diabetes. Diabetes also has a huge image problem. So you can go to any newspaper, any online media, any if you just Google campaigns, you see lots of images like this. There's news reports that talk about diabetes threatening to overwhelm hospitals, as though people with diabetes are just a burden on the state and on society and on taxpayers, that all diabetes is due to poor diet. You get articles that are demonstrating that with images of donuts and placed next to headlines such as type 2 diabetes, the fastest growing chronic condition in Australia. And this doesn't just happen in Australia, this happens in numerous countries around the world. And then, of course, in our academic literature as well, we still see language like patients failing to achieve their targets, patients being poorly controlled, and so on. So there's still a lot of work that needs to be done around the language that's being used, but also around the imagery that's being used. The imagery is not just in the media, it's also in the campaigns that come out of diabetes organisations and other organisations related to healthcare areas. A couple of years ago, Renza, who's in the audience here, and Tim and I got together with Andrew Bolton, who was the president of the International Diabetes Federation at the time, and we wrote this commentary that appeared in the Lancet Diabetes and Endocrinology about diabetes campaigns and the damage that they do to the cause that they aim to serve. So by portraying these kinds of campaigns that are really just stigmatizing diabetes, we're really doing a disservice to people living with diabetes, people affected by diabetes, people at risk of diabetes. It's really not okay that we put these campaigns out, and I'm very pleased to say that there's a lot of work going into various organisations around the world, including our own here in Victoria, to make sure that these kinds of campaigns are a thing of the past. But here's an example in retinopathy. So these are the kinds of campaigns or promotion leaflets that are used in clinics. So not necessarily in national campaigns, but when you Google for the kinds of things that health professionals and health services are trying to use to increase the uptake of screening for people with diabetes, this is the kind of thing you see, and it's not very appealing. It's not the kind of thing that's really making someone get off their seat and go, oh gosh, I must really go and get my eyes checked. It's really quite demotivating. These fear appeals are appealing to health professionals, but they're not appealing to people with diabetes. So in response to this post on Twitter a few years ago, there were quite a lot of responses from community about this, suggesting that the health professional is probably just going to alienate that 28-year-old from attending her eye screening. Do you know if she went to her car and cried from helplessness like I used to after eye exams, who had this kind of bedside manner? It took me some time to find eye docs who could be helpful and create a plan instead of send me off alone and frightened. And this mentality scarred me into doing something better briefly as a teenager, but soon enough it led to hopelessness and years worth of higher HbA1cs. So while health professionals and health services are often trying to do their best in terms of encouraging people or trying to motivate people to come for screening, actually they're doing more harm than good by this type of messaging. And importantly, we've got studies that demonstrate that actually, rather than underestimate their risk of complications, most people with diabetes are actually overestimating their risk of complications. And that's actually contributing to the diabetes distress that they're experiencing. We see this across the board, across the world, that the number one problem area of people living with diabetes is fearing the future and the risk of complications. And these charts are showing you that where these arrows are is actually where the risk is. The proportion of people is underestimating their risk is on the left, and in the red circle on the right, or the red square on the right, it's showing you how many people are overestimating their risk for any particular complication. So a few years ago, Dr. Amelia Lake in our team, actually when she was doing her PhD, did a whole program of research looking into how to provide more appropriate, positive and tailored messaging to support young adults with type 2 diabetes and older adults with type 2 diabetes to go for screening for eye health. And I'm not going to go into the details of this, but what you can see here, just in terms of the imagery used on the left-hand side here, it's just far more appealing. And the question is who's looking after your eyes, not a aberration of you must come for a health appointment or you must come for an eye check. And again, this work is backed up by evidence and published papers. So as I've mentioned, the diabetes campaigns in Australia have been improving. They were pretty scary over a decade ago. They have got better over the years, I'm pleased to say, and I hope that they continue to get better into the future. Of course, we just actually don't know enough about what it takes to produce an effective campaign, and I don't have time today, unfortunately, to go into any more about that, but Liz Holmes-Truscott, who's here in the audience, is doing some great work in this space, and we hope to be able to tell you more about that in due course. So all of what I've talked about really it brings us back to the issue of diabetes stigma. And as many of you will know, last year, Liz and I were very privileged to co-lead this international consensus to bring an end to diabetes stigma and discrimination with some amazing people, 51 people around the world, including Renza, who's here, Jennifer in our team, Tim in our team, but many other people around the world, a third of whom have diabetes themselves, all of whom are passionate advocates or researchers or clinicians working in this area. This paper is free to download. It was available in the Lancet Diabetes and Endocrinology in January. In that consensus, I'm not going to go into detail about what we did to achieve that consensus, but grade U means unanimous consensus. So every one of those 51 experts agreed. And you can see here that in each of these 6 boxes around the various consequences of diabetes stigma, all of those were unanimous consensus. So diabetes stigma is having a negative impact on people's general and emotional well-being, on their clinical outcomes, on behaviours, on access to healthcare, on their social and professional lives, and on public and political support for diabetes prevention programs, diabetes care, treatment and research. You can see a couple of quotes at the top of the screen here that just give you just a small indication of what that feels like for people in terms of their self-esteem and their general emotional well-being. So yesterday was World Diabetes Day. A year ago, we launched on World Diabetes Day. We celebrated the international consensus and launched the pledge to end diabetes stigma. That pledge is available at a website called enddiabetesstigma.org. And there's a hashtag #enddiabetesstigma. The pledge has been taken by over 300 organizations around the world, by almost 3,000 individuals around the world in over 105 countries around the world in just over a year. I think the most impressive statistic there is the 105 countries. I think we can do a much, much better in terms of the number of organizations and the number of individuals. But I'm delighted to see that it's literally gone halfway around the world in terms of a movement. And yesterday was World Diabetes Day. And I woke up this morning, and I'm going to get very emotional now because this is a really amazing set of social media to wake up to the day after World Diabetes Day here in Australia, to see that the rest of the world came to the party. So a year after we'd launched it, Diabetes UK, Diabetes Canada, the European Association for the Study of Diabetes, Wiley Journals, publishing house, they've all been talking about diabetes stigma. The theme for World Diabetes Day is well-being, but they chose to put their emphasis on stigma, which is really amazing. In particular, I'll draw your attention to Sir Steve Redgrave, 5-time Olympian, who's backing Diabetes UK's campaign, which is this campaign here, If You Knew, which is a community-led campaign with people submitting their stories about what it's like to live with diabetes. If you only knew what your reaction was like, if you only knew what that did to me. There's some amazing stories already coming up online, so I encourage you to have a look at that. And it's fabulous that someone of Sir Steve Redgrave's profile is backing that campaign. We need more public profile people backing these kinds of things. And this other campaign here from Diabetes UK, Unraveling the Drivers of Type 2 Diabetes Stigma. I had a read of that this morning. I've never ever read a website about the drivers of type 2 diabetes that's so impressively comprehensive about what type 2 diabetes is actually about. It goes through the genetics and the environmental determinants and the biological determinants and the behaviors and everything else along with it. And right at the bottom, it talks about the stigma that people experience. So it's really impressive. This is not just people standing in front of a camera and smiling and saying, hey, we're doing something about stigma. This is people actually taking a very comprehensive approach to addressing a very complex issue. Diabetes UK are also funding research in this area, and so that's what this social media posters exploring. And then there's schools that are taking up the mantle, and Diabetes Canada over on the right-hand side there. The CEO is talking to camera there about her own personal experiences of living with type 2 diabetes and the stigma that she's experienced and what she feels would have been more helpful at diagnosis from her health professionals. And the World Health Organization right in the middle there with some great imagery and messaging being put forward in cartoons. So this is really what we were talking about when we said we would bring an international consensus, when we said we would put out a pledge, and we hoped, probably beyond hope really, that people would take it up. But actually it's really fantastic to see this collective action, this collective leadership from across the world that's happening because we did this, we started this. And yeah, I'm really pleased to also say that here at Diabetes Victoria, we have stigma as goal 4 of our strategy that was newly launched a few weeks ago. Wonderful to see that on the website, wonderful to see Glenn talking about it at the Kellyan event on Tuesday, for it to be shown in that video and be right up on the screen, and for people to know that that's a fundamental goal of this organisation to reduce the harmful effects of stigma is really important. So I'm going to wrap up. From a 1994 guideline to a 2024 Diabetes Wellbeing Manifesto. It's taken 30 years. There has been a lot of progress in this area, but as I hope to have shown you, there's also challenges and there are still lots of opportunities to do better in this space. So for 2024 and beyond, I challenge us all to do diabetes care as if people mattered. Absolutely must thank everyone in the ACBRD team, many people whose work I've talked about today, many people whose work I haven't talked about because there just wasn't enough time and I had to cut really important things just to make sure that we would finish roughly on time. I'd like to thank not only the current team, but many people who are no longer part of the team, who haven't been working with us for a little while, but their work remains really important and valuable to us. And there's also a few people who are not shown on the screen that got missed, and apologise for that. And in the bottom right-hand corner there, I would also really like to thank Glenn Noonan, who's here today, and Rachel Huxley. Diabetes Victoria and Deakin University have supported the ACBRD for the last 15 years, and it's a great privilege to work for both organisations. And it's really wonderful that they have continued to support us every 5 years for the last 15 years. So we're really grateful for that continuing support. And I must also mention the local, the national and the international collaborations that are so important to the work that we do. So it's not just our own team, it's the conversations that we have with others, it's the formal research projects that we work on, it's the advocacy work that we all do together. It really does take, you know, a whole world of collaborations, and we're really grateful to everyone that works with us on the projects that we have. So thank you to everyone who's involved. And I think the last 2 words are, I would really like to acknowledge all the people with diabetes who've taken part in our research. We're really grateful to them for sharing their time and their insights with us. And then the final word goes to Tricia. The language we use is not consistent with personalised care. Be horse whisperers, not horse breakers. Thank you very much. Happy World Diabetes Day.
Well, thank you, Jane. I'll just be brief in terms of a couple of wrap-up comments. Before I come to Jane, I think a couple of comments in regards to Trish Dunning. I think Trish would be just super proud, firstly, that this series, you know, we've kicked this series off, and your lecture today. It was just fabulous, and I think it just had so much of Trish in it. I got to know Trish myself when I first joined Diabetes Victoria board. She was on the board. You know, my recollections and my memories, Trish just welcomed me to the board so warmly. I think she sort of took me under her wing a little bit to try and educate me. And that was just so fabulous. She was a giant on a worldwide stage. She was the vice president of the International Diabetes Federation. She's still talked about globally in terms of the international conferences and the likes, in terms of her impact. So she was just a wonderful, caring person, and I think this lecture series is just such a great way to continue to recognise Trish. The partnership between Deakin and Diabetes Victoria, which the ACBRD is the result of, I think I just want to acknowledge Deakin in terms of their role in the partnership. It's nearly 15 years. It's a pretty wonderful position to, sometimes we refer to Jane as the founding director. She is the founding director, but to have the same director for such a long period of time and to see the progress over that period of time is just fantastic. It's a pretty unique model to have two organisations, a consumer-driven organisation and a research academic organisation, essentially set up and fund such an important area of research. And so, we're really proud of that and to be able to continue it. And finally, Jane, thank you for championing this work. You always amaze me in terms of quality of your presentations. It's such a clear and compelling presentation. And there is just no doubt that for people to live the lives that we want them to live, these areas have to be improved. And I think, that's the truth of it. And you can look at it in various different ways, but we want to see improvement in these areas. And I think you've just laid that out so clearly in your manifesto. So thank you for that. I think then the last comment, it's really, pretty impressive in terms of the progress that we have seen in the last 12 months. You sort of went from 19 to over 24 years, and it almost feels like the progress has accelerated in that last 12 months. And that last slide, in terms of some of the themes that globally organisations have put out in the last 24 hours in terms of stigma and so on, I think speaks volumes. It speaks volumes for the work that was kicked off just 12 months ago and led by the ACBRD. And that's a great tribute to the entire team, Liz as well, Renza for your involvement in that as well, and Jane. So I'll leave it there. Thanks very much for the first lecture in a series that will be many, many to come. Thank you.